Asthma is an inflammatory disease of the airways to the lungs. It makes breathing difficult and can make some physical activities challenging or even impossible. At the moment, there's no cure for asthma. However, there are many effective treatments that can decrease asthma symptoms, or what we know as symptomatic treatments. As mentioned in the previous video, there are several classes of drugs used in asthma. In this video, we are going to look at the bronchodilators. The three most widely used bronchodilators are the beta-2 agonists such as salbutamol or salmeterol, the anticholinergics or muscarinic antagonists such as Ibratropium and Theophylline, as well as the methylxanthins such as Theophylline. As the name suggests, all of these drugs work to reverse bronchoconstriction during an acute asthma attack. So in this video, let's go over each of them in turn. Let us first take a look at the beta-2 receptor agonists. These agents bind to G protein-coupled receptors in the airways, and activation of beta-2 receptors leads to activation of adenylate cyclase and subsequent generation of cyclic AMP. Increased levels of cyclic AMP in turn activate protein kinase A. Protein kinase A phosphorylates myosin light chain kinase. Phosphorylated myosin light chain kinase is ineffective in sustaining the interaction between actin and myosin, and therefore the bronchial smooth muscle relaxes. Additionally, protein kinase A activation inhibits phosphoinositide hydrolysis and calcium mobilization, also causing bronchial muscle relaxation. Beta-2 receptor activation also stimulates calcium-activated potassium channels in airway smooth muscle. Hyperpolarization resulting from this mechanism will cause a deactivation of voltage-dependent calcium channels, resulting in a decreased calcium influx, which will then favor smooth muscle relaxation. So as you can see, beta-2 agonists exert its bronchodilatory effect via several pathways. Beta-2 agonists are mostly delivered via inhalation route or oral route of administration. Inhaled therapy delivered directly to the lungs is preferable to systemic oral therapy for many reasons. Inhaled therapy produces more bronchodilation, causes fewer systemic side effects, has a faster onset of action, and achieves desired results at a lower dose as compared to systemic oral therapy for asthma. Beta-2 agonists can be given via metered dose inhaler or compressor-driven nebulizer. As compared to inhaled route of administration, oral beta agonist needs larger doses to exert its action. It is associated with more adverse effects since it is spread systemically in the body compared to inhalation route, which delivered drugs at a localized area, in this case the airways of the lungs. The onset of action is also slower with oral administration compared to the inhalation route. Teophyline can be given via subcutaneous injection in emergency treatment of severe asthma. Selective beta-2 agonists differ in terms of their speed of onset and duration of action, and are categorized into short-acting beta-2 agonists or long-acting beta-2 agonists, which despite their common site of action have different indications in the treatment of asthma. Metoprolol has the quickest onset of action of any beta-2 agonist for asthma when inhaled. Albuterol is the standard of inhaled beta-2 agonist used to manage bronchospasm. Teophyline is the only beta-2 agonist that can be used for subcutaneous injection in the emergency management of status asthmaticus or severe asthma. Salmeterol has the longest duration of action of any beta-2 agonist, and it should only be used for the maintenance treatment of asthma and not for treatment of acute attacks of asthma. It is postulated that the lipid bilayer of airway smooth muscle acts as a storage depot for beta-2 agonists, such that beta-2 agonists that partition into the bilayer to a large extent remain available to bind to the beta-2 receptor for extended periods of time after they are administered. Salmeterol is believed to have a slower onset of action due to its high degree of partitioning into the lipid bilayer and slower rate of drug diffusion through the bilayer to its receptor site, in contrast to other beta-2 agonists that gains access to the same receptor via an aqueous pathway where diffusion is much more rapid. Adverse effects of short-term use of specific beta-2 agonists are relatively minor and infrequent due to their high specificity and topical delivery. The potential for adverse effects is greater when these agents are used orally. Skeletal muscle tremor is most common and usually occurs as fine finger tremors. Tachycardia do occur, and this might be a result of non-selective direct stimulation of heart rate by beta-1 receptor and the reflex stimulation of heart rate from beta-2 receptor-mediated peripheral vasodilation. Anxiety, restlessness, and apprehension might also occur in some patients, and it might limit the use of beta-2 agonists as a therapy. Let us now move on to the second bronchodilator, which is theophylline. There are several proposed mechanisms for the beneficial effects of theophylline in asthma. The first involves its ability to inhibit cyclic nucleotide phosphodiesterases, which in turn inhibits the degradation of cyclic AMP. Increased levels of cyclic AMP in turn leads to bronchodilation, similar to the mechanism that you see with the beta-2 agonists, as well as decreasing release of inflammatory mediators from mast cells. Theophylline is a relatively non-selective inhibitor of phosphodiesterases, and it is this lack of specificity that may contribute to some of the adverse effects that are observed with theophylline use. A second proposed mechanism of action of theophylline in asthma centers around its ability to antagonize or block adenosine receptors in the airways. Adenosine actually induces both contraction of smooth muscle and the release of inflammatory mediators from mast cells. Thus, the antagonism of adenosine receptors by theophylline may prevent both of these adverse events in asthma. Theophylline for the treatment of asthma can be given orally or by intravenous infusion. Oral doses of theophylline are available in standard short-acting and prolonged release or sustained release oral preparation. For standard preparation, the onset of action is within 45 to 60 minutes, with a duration of action between 4 to 6 hours. And for sustained release oral preparation, the duration of action ranges between 8 to 24 hours. Therefore, theophylline is quite useful in the control of nocturnal asthma. Theophylline can be given via intravenous route, and they are given as an ethylene diamine complex, and this is given by a slow infusion, specifically for the management of acute severe asthma. Theophylline is hydroxylated and demethylated in liver and excreted by kidneys. The mean half-life of theophylline is shortened by cigarette smoking. So smoking actually induces hepatic enzymes that degrade theophylline. So the half-life of theophylline in a non-smoking adult is 9 hours, whereas the half-life of theophylline in a smoking adult is only about 5 hours. The mean half-life of theophylline is prolonged in patients with a decrease in hepatic blood flow, for instance from congestive heart failure, in patients who have a decrease in hepatic function, such as in cirrhosis, and it is also prolonged in patients with obesity who are on oral contraceptives and have viral upper respiratory tract infection. The monitoring of serum concentrations of theophylline is very important because of several reasons. First and foremost, the range of safe therapeutic serum concentrations of theophylline is very narrow, ranging between 5 to 15 micrograms per ml. Inter-individual variability of theophylline clearance is very large, And theophylline has significant dose-related toxicity. So, as I mentioned earlier, the therapeutically effective serum concentration of theophylline is between 5 to 15 micrograms per ml, and this is very close to the toxic concentration of theophylline. Therefore, periodic monitoring of drug levels is strongly recommended. If serum theophylline levels remain below 15 micrograms per ml, adverse effects are rare. At serum theophylline levels from 20 to 35 micrograms per ml, usually there would be manifestations of side effects such as headache, dizziness, nervousness, and insomnia, as well as nausea and vomiting. Epigastric pain might also be present due to theophylline relaxing the gastroesophageal sphincter, which leads to acid reflux into the esophagus and heartburn, since theophylline can also increase gastric acid secretion. At serum theophylline levels above 35 micrograms per ml, they can cause marked CNS stimulation, leading to agitation, hyperreflexias, tremors, and even convulsions. And the convulsions are especially dangerous because they can occur without warning signs and may be refractory or non-responsive to standard anticonvulsant therapy. So it might lead to death, or severe residual effects might even be possible. The cardiovascular effects of theophylline are also significant and may include tachycardia, increased cardiac output, and of greatest concern with high blood levels, cardiac arrhythmia, and sudden death. Theophylline can cause a very pronounced elevation in body temperature in children, and it can also lead to relaxation of bladder muscle, and this may cause urinary retention in older men with enlarged prostate. Last but not least are the muscarinic antagonists, which are another group of bronchodilators. Asthma, as you know, can be associated with vagal-mediated stimulation of bronchial smooth muscle, causing bronchospasm and mucus secretion. Ibratropium bromide inhibits the effect of acetylcholine released from airway vagal nerves by antagonizing the muscarinic receptors in bronchial smooth muscle cells, resulting in a decreased concentration of inositol triphosphate, which leads to a decreased release of calcium ions from the endoplasmic reticulum, causing relaxation of bronchial smooth muscle. Blocking cholinergic activity likewise blocks the increase in mucus secretion that occurs in response to vagal activation. Ibratropium bromide is a quaternary ammonium anti-muscarinic agent, and this was developed way back in 1970s as an inhalation agent with limited systemic absorption and CNS penetration. The potency of ipratropium as a bronchodilator is generally lower as compared to beta-2 agonists, and the bronchodilator response of patients to ipratropium also shows greater variability than does the response to beta-2 agonists. So there are research to suggest that a significant amount of pharmacogenomic variations in the parasympathetic nervous system and airway receptors of different individuals, a finding that may help explain the varying efficacy of anticholinergic drugs in asthma patients. Ibratropium bromide are available in metered dose inhaler or a nebulized solution with an onset of action within 30 to 90 minutes and a duration of action of up to 5 hours. Hypertrophium is very safe because it is poorly absorbed when inhaled, resulting in a very low blood levels of the drug. The most common side effects reported with inhaled ipratropium use are cough, dry mouth, and throat irritation following inhalation. But I guess one of the things that you might want to consider telling patient when counseling them is to ask them to close their eyes to avoid accidental contact of the spray with their eyes, or else they will have blurred vision for near objects due to the dilatation of pupils that is mediated by the antagonism of muscarinic receptor in the eye. Let us do a quick recap of the bronchodilators we have covered in this video. Beta-2 agonists are the most potent bronchodilators currently approved for treating asthma and obstructive lung diseases. At the cellular level, activation of beta-2 receptors produces bronchodilation through multiple pathways, most of which involve stimulation of adenylate cyclase and phosphorylation of target proteins by protein kinase A. Depending on their duration of action, they are used as either rescue medications, which are the short-acting beta-2 agonists, or control medications, which are the long-acting beta-2 agonists. Theophylline is a relatively non-selective inhibitor of phosphodiesterases and antagonist of adenosine receptors. Although a potent bronchodilator, its use is restricted owing to its narrow therapeutic index and significant dose-related toxicities. Last but not least, you have the muscarinic antagonists, and of course, as the name suggests, it antagonizes the action of acetylcholine by blocking muscarinic cholinergic receptors. Muscarinic antagonists can be further subclassified into the short-acting muscarinic antagonists, for instance Ibratropium, and the long-acting muscarinic antagonists, for example Theophylline. The potency of Ibratropium as a bronchodilator is generally lower than that of beta-2 agonists, and the bronchodilator response of patients to Ibratropium also shows greater variability compared to beta-2 agonists, most likely attributed to pharmacogenomic variations. If you feel that this video is helpful, please hit like, and we'll continue with other topics of anti-asthmatic drugs in the next videos.